I'm Sean McBride, a GU Radiation Oncologist from Memorial Sloan Kettering. I'm here to present the best of GU Radiation Oncology at our Onco Alert 2026 colloquium. I'll be talking about five trials. Two of the trials focus on oligometastatic prostate cancer, two of the trials focus on definitive prostate cancer, and one focuses on biochemically recurrent prostate cancer. So without further ado, let's start with PCS9. This is a trial by Dr. Niazi of metastasis-directed therapy in addition to standard systemic therapy in oligometastatic castrate-resistant prostate cancer. This trial obviously enrolled patients with hormone-resistant prostate cancer. They had oligometastatic disease defined as 5 or fewer lesions, here by conventional imaging, so there was no PSMA PET imaging. Importantly, patients on this trial could not have had ARPI therapy. So these patients were progressing on ADT alone. They were then randomized 1-to-1 to either Enza added to ADT or Enza plus metastasis-directed SBRT. The SBRT dosing was fairly common, fairly typical. Again, standard imaging was used for follow-up on this protocol, whole body bone scans or CT MRs of the chest, abdomen, and pelvis. You can see the follow-up here. The primary endpoint was progression-free survival, and a critical secondary endpoint was time to next systemic therapy. So, what are the results? Well, after a follow-up of 4.8 years, the median radiographic progression-free survival was improved with SBRT. The median biochemical progression-free survival was improved with SBRT. And the time to next systemic therapy was significantly improved with the addition of SBRT on top of Enza. There were no difference in adverse events. You can see the Kaplan-Meier curves, the radiographic progression-free survival, a nice separation at 1 year, and not unsurprisingly, the cumulative incidence of new systemic therapy obviously tracked the radiographic progression-free survival. You can see a large difference starting at a year favoring the ADT Enza SBRT arm. Just a couple mentions about the population of this trial. Most of these patients had 1 or 2 metastases, about 75%. You can see it's a small trial, 48 patients and 52 in the respective arms. What the SBRT did was essentially shift the pattern of recurrence. Absent the SBRT with the Enza alone, a lot of the progression was in the already existing disease. The SBRT shifted that to new lesions. What's our conclusion from this trial? Well, SBRT added doublet therapy in hormone-resistant prostate cancer should be considered a standard of care. A couple caveats here. I'd say there's really 2 types of hormone-resistant prostate cancer. There's patients whose disease is progressing on ADT alone. You don't see that a lot in academic medical centers where a lot of patients are on doublet therapy at the time of initial metastatic progression. Or there's patients who are progressing on the doublet therapy. Now, this trial looked at that former population, the patients progressing on ADT alone. You know, in clinical practice, oftentimes when we see castrate-resistant patients, the question we're being asked is, well, do we add SBRT in lieu of next systemic therapy, not in addition to? So it's a slightly different question that we're frequently encountering in clinical practice. But this represents some outstanding level 1 evidence in the castrate-resistant space in favor of SBRT in addition to RP therapy. Next trial is in the hormone-sensitive space. This is Dr. Kishan's LUNAR Trial. This is an outstanding study looking at the addition of neoadjuvant lutetium to SBRT in oligometastatic disease. Again, oligomets was similarly defined, but using PSMA PET. Castrate-resistant patients were excluded. This was, as was de novo disease. This was a single center phase 2, again, relatively small. Patients were randomized to SBRT or neoadjuvant 2 cycles of Pluvicto plus SBRT. Again, the SBRT dosing fairly uniform. The 2 cycles of Pluvicto were separated by about 8 weeks. Follow-up, you can see here, every patient had a PSMA PET at 12 months or at progression. The primary endpoint for this trial was progression-free survival, defined as time until PSMA PET progression, salvage ADT, or death, so it's a composite endpoint. PSMA PET progression was defined as a new lesion or a 30% increase in the SUV of existing lesions, or in the sum of a 20% increase in the sum of the longest diameters in existing lesions. Median follow-up was 22 months, fairly robust. These patients had very low volume oligometastatic disease. So by conventional imaging, the vast majority were M0. And when you looked at the PSMA PET, which is how they were staged, they had either one or two lesions. So this is very low volume metastatic disease. Despite that, you saw a dramatic improvement with the addition of the 2 cycles of Pluvicto before the SBRT. Progression-free survival with SBRT alone was 7.4 months versus 17.6 months with the addition of the neoadjuvant Pluvicto. Importantly, patients tolerated this quite well. As people know, Pluvicto can have hematologic toxicities, it can have xerostomia, but really no significant differences with just the 2 cycles. This is very well tolerated. You can see here the time to radiograph to progression-free survival here, a nice separation of the curves quite early on, favoring obviously the neoadjuvant lutetium added to the SBRT. And then a very important endpoint, time to hormonal therapy. Again, patients who got the neoadjuvant Pluvicto are staying off hormonal therapy for longer. So what's our conclusion from this one? 2 cycles of lutetium prior to SBRT in hormone-sensitive prostate cancer is a clear alternative to SBRT. Obviously, Pluvicto is not yet approved in the hormone-sensitive space, but once it is, this will be a great option for patients who may be just considering SBRT alone. You get the patient will enjoy a more extended PFS with what looks like to be fairly limited to minimal toxicity difference compared to SBRT alone. I think the most pertinent next question to ask is whether how Pluvicto plus SBRT stacks up against ADT, short course ADT plus SBRT. Short course ADT plus SBRT is probably our most common therapeutic regimen in the oligometastatic hormone sensitive space. Moving out of oligomets into definitive prostate cancer, our next trial is the long-awaited RTOG 0924. This is a trial looking at the addition of whole pelvic elective radiation to prostate-directed radiation with long course or short course or long course hormone therapy in patients with unfavorable or intermediate or favorable high-risk prostate cancer. These patients had to have a 15% probability of nodal involvement by the Roche formula. This is not NCCN, unfavorable intermediate risk or favorable high risk. Here, favorable high risk was defined as no T3 and a PSA less than 50. So a lot of those favorable high risk probably would meet the criteria for NCCN very high risk. These patients were conventionally staged, not surprising given when this trial first started enrolling. This is a large cooperative group trial, randomized 1-to-1 to whole pelvis or not. The prostate-directed radiation, fairly standard, maybe a little bit low dose on the EBRT. The ADT choices was 6 or 32 months. The pelvic RT, 45 gray and 1.8 gray fractions, again, standard. Primary endpoint, overall survival, is a huge trial. 2,500 patients were enrolled, evenly split between the unfavorable intermediate risk and the favorable high risk. Robust follow-up of 7.3 years. 30% of the patients received long-course ADT, and a good number received brachy boost. You can see a screenshot of the table 1 here. Importantly, no difference in overall survival, no distance in distant metastasis-free survival, and even the biochemical cumulative incidence of biochemical failure. This is usually a pretty easy endpoint to hit. Very minimal difference, 17% versus 13%. Even though it was significant on a one-sided P, it's not a big difference. It's not a big difference at all. Obviously, there's a slight increase in GI toxicity. So for me, there's no benefit. The conclusion here is no benefit for elective whole pelvis radiation in unfavorable intermediate risk or favorable high risk patients. Again, many of those probably had NCCN very high risk. Likely to be even less benefit if they're in the already marginal benefit in BCR, or already marginal benefit in biochemical recurrence with the PSMA PET stage patients. How do we square this with POP-RT? POP-RT obviously is the trial out of Tata Memorial Hospital from JCO in 2021. That was a much smaller trial. Those patients, I think, had much bulkier disease than the patients enrolled in the RTOG trial. So, it's a little bit of an apples to oranges comparison there. Now, the vast majority of the patients we're seeing in practice probably would fit the criteria for RTOG 0924. A question I always ask, even though pelvic RT doesn't provide an incremental benefit, could it be substituted in and sub out long course ADT? In other words, does delivering pelvic RT abrogate the need for long course ADT, perhaps in certain high risk patients? It's an interesting academic question. Maybe a future trial will address it. Our next trial, long-awaited Enzarad, Dr. Nguyen's ANZUM trial. This was presented at ESMO in 2025. This is high-risk localized or N1 patients. These patients all received prostate-directed radiation, investigator's choice of pelvic RT. Everyone got long-course ADT, and then they were randomized plus minus enzalutamide. open label phase 3 trial, a lot of stratification variables, which allowed them to really delve into some of the subgroups. Primary outcome was metastasis-free survival on conventional imaging, and you can see the secondary endpoints here. Again, big trial, 802 patients, robust follow-up, 89% had Gleason 8 to 10, 47% had clinical T3 to T4 disease, 35% with a PSA less than 20, and 11% had N1 disease. And again, this was a largely negative trial. MFS, no difference between the arms for taking all comers, no difference in OS, no difference in prostate cancer specific survival. Yes, there was a two-sided p-value that was significant for PSA progression-free survival, but the absolute magnitude of the difference, trifling in my opinion. I'd call it maybe clinically insignificant. Now, when you delve into the subgroups, which was the genius of this trial to pre-specify, N1 patients benefit. Patients who got whole pelvic radiation, this was a larger proportion of patients who got whole pelvic radiation than who had N1 disease. But remember, this is conventionally defined N1 disease. So I bet a lot of those whole pelvic patients who didn't have N1 by size criteria had suspicious looking nodes. So the patients who got whole pelvic radiation, this is a larger subgroup than but obviously included the N1 patients, they benefited. Conclusion here, no benefit for ENZA and N0 patients, clear benefit in N1. Probably if you have some indeterminate nodes that look a little rounded, you're a little suspicious by, they probably benefit too. How do we square this with STAMPEDE? Well, STAMPEDE, it looks like probably just it was enrolling higher volume patients. Again, the median PSA much higher in STAMPEDE, higher proportion of clinical T3, T4. So that probably made the difference. That's probably why the N0 patients in STAMPEDE might have had a benefit with the addition of ARPI where you didn't see that ENZA-RAD. Our final trial, moving out of the definitive space into the salvage space. This is a trial of Dr. Spratt's excellent trial, Energy GU 006. This is looking at whether the PAM50 classifier can help predict for the benefit of short course ARPI in these BCR patients. So again, this is biochemically recurrent prostate cancer. Patients had to have a PSA between 0.1 and 1. They were N0, M0, presumably by conventional imaging. This was an energy phase 2 blinded, a sizable phase 2. All patients had the Decipher score. They extracted their PAM50 subtype, stratified by these variables, most importantly, the PAM50 subtype. And then they were randomized to bed alone RT or bed alone plus 6 months of APA. The bed dosing, very standard. Primary endpoint was biochemical progression-free survival. I think that's significant here for the salvage setting because these patients, if they fail, are going to probably go on to at least intermittent ADT. Secondary look at MFS. I think it's important to note here on the table one, most of these patients had Gleason 7 disease, okay? This was not a trial of Gleason 9, 10 patients. The PAM50 breakdown, luminal B, again, this trial was the hypothesis that drove this trial was based off of JAMA Onc paper from 2017, showing that the luminal B patients might actually be the ones that would benefit most from short course ADT. So you see the luminal B here, 43%, the non-luminal B, 57%, and this was an awesome predictor of benefit from apalutamide. In the luminal B subset, clear benefit for APA with biochemical progression-free survival, clear benefit for MFS. The non-luminal B, no real benefit on either one of those endpoints. So there's a clear benefit for short course ARPI in salvage radiation limited to the luminal Bs. The non-luminal Bs didn't appear to benefit. Question is, does this extend to generic ADT, LHRH agonist? I don't see why it wouldn't. We're impacting the same biological pathway. Maybe an interesting question of how would the inclusion of nodal treatment, a lot of us include elective pelvic nodes in the BCR setting, given support showing a biochemical recurrence-free survival benefit that's fairly, it's not trifling. Would that have impacted the predictive capacity of the PAM50 here if you included the nodes? I don't know. It might have just reduced the magnitude of the benefit, but probably wouldn't have abrogated it. How do these trials change practice? These are great trials, 2 published, 3 in abstract form. In the oligometastatic setting, I think for me, once Pluvicto is approved in the hormone-sensitive space, patients who you're considering just SBRT alone, patients with maybe a long interval between salvage radiation and oligometastatic recurrence, oligoprogressive patients maybe with a long interval. When you're thinking maybe just SBRT alone, patient wants to avoid ADT especially, I think adding neoadjuvant 2 cycles Pluvicto makes sense. Even if, the downside risk, the toxicity seemed relatively minimal. Dr. Niazi's trial really showed us that SBRT has a role in the castrate-sensitive space, even though the types of patients enrolled there are not necessarily the most common we're seeing in academic medical centers. In the definitive setting, no elective nodal radiation, in my opinion, for standard high-risk patients. I've eliminated that in my practice. And I think once we see the publication itself, I think we're going to be able to eliminate elective nodal irradiation for a good number of the NCCN very high-risk PSMA PET stage patients. The other big take home from the definitive trials is the ENZARAD trial, to me, really cautions us against the overuse of ARPI in high risk prostate cancer patients. I think if bulky disease, if they're meeting STAMPEDE criteria, sure, but if they're not meeting STAMPEDE criteria, if it's not really bulky localized disease, ADT alone is probably, long course ADT alone is probably A-OK. In the salvage setting, remember, these are Gleason 7 that were enrolled in Energy GU006. So for like a T3 Gleason 7, I'm using the PAN50 to help make determinations about short course ADT. And I think that's reasonable. So these have been some, I think, truly outstanding trials. I congratulate the trialists. We're really excited to see the publications of the ones that were presented in abstract form. And I want to thank everybody for their attention.